All right, so I was telling Jessica this morning that this is probably going to be one of the biggest changes that we've seen as coding nerds since ICD-10. But the good news about it is the coding guidelines are finally going to be a little bit easier. You know, when I look around at all of you, I probably can assume that there are, 10 or 15 of you that really do a lot of E&M auditing. You probably don't live your life just looking at E&M notes. You're pretty much entering, and then now EMRs are, calculating the codes for us. But this new change that goes into effect in January is something that as coders we're going to want to know a little bit about, and the good news is that you might get a better opportunity of learning about E&M coding, because it's a little bit easier now. So you have two handouts in front of you. I'm going to talk to you for probably 30 minutes about where we are now, and then about 30 minutes on where we're going. So one handout says 2020 compliant E&M coding, and it's up and down. And the other one is 2021. We'll go to that one second. But it's still really important if you have doctors who go to the nursing home, who go to the hospital, who go to the emergency room. There's going to be two sets of E&M coding guidelines now, So the only thing that's changing are the ones that are in the office or outpatient setting. So 99201 through 99215. So, what that does is it's going to free the government up, if they want to audit more hospital notes, more nursing home notes, more ER notes, assisted living, home visits. So if you're in primary care, it's pretty good because your life will be a little bit easier. But if you're in a multi-specialty, it's going to be difficult for your docs because they'll have two rules to remember. This is probably the fewest things I've ever talked about. So we just have two things, 2020 and 2021. To get this whole thing started a few years ago, before the 2018 election, the American Medical Association went to Congress and said, we don't care who gets elected president, you've got to do something about documentation guidelines. So what we've noticed over the last couple years is this thing called the Reduction in the Administrative Burden Act. And what that does is it's basically just reducing the amount of notes that doctors have to do. Last year, Medicare even allowed medical assistants for the first time to legally document the history of the present illness. Now, many of you have probably always had your nurses and medical assistants doing that, but it was illegal under Medicare guidelines for anybody but the provider to document the HPI. So we were all violating that rule anyway. This year, Congress came out and said, well, now even if you have a nurse practitioner student, a PA, or anybody, they can document elements of the history if you want. You just have to review and validate their notes. Last year, Medicare even said, listen, if you're seeing a patient today and their physical exam is the same as it was the last visit, you can just refer to that exam. You don't even have to redocument it. So the biggest thing that I would kind of take away, and I'll try to give you a few nuggets, is that you're going to probably see some kind of change in your EMR in the next 11 or 12 months. That'll incorporate some of the new coding guideline requirements, because all that stuff that you used to carry over, the review of systems, the medical, family, social, things that I'm going to talk about in the first 30 minutes that you're going to still need in the hospital, the nursing home, and everywhere else, you're not going to need in the office. So get ready for that, and hopefully those upgrades will be free. But the big takeaway is for right now, just make sure that somewhere in your notes, if you have ancillary people other than the provider documenting the history, that somehow there's some kind of smart text in your note that just says, elements of the history have been reviewed and I agree with the findings. It's something simple like that, just to be on the safe side. So we'll move into E&M coding. Medical necessity is still going to be the most important component, and this is one of the areas where a lot of EMRs messed up. So if you have the 2020 coding handout and you go to page 3, this is the one that's it's the one that's portrait, not landscape. There you go. You'll remember the codes are on the left-hand side, page 3. Then there's minutes. Do you see that? Minutes. Then there's a column for the history, a column for the exam, and a column for the medical decision making. Those are the three key components of an E&M code. When I got hired in 1992, all I did was fly around the country explaining how this system worked to doctors, and I'm going to be doing it again tonight to your doctors, so it's been really good for me and my family. But the government said this is just too complicated. So then EMRs came out and they said, well, we'll make it easier. But if you put your finger on 99214, the bottom left-hand corner, that's an established outpatient E&M visit. It requires two of those three key components, the history, exam, and decision making. Do you see that? Now what a lot of EMRs do is they just calculate your level of service based on the first two, the history and the exam. So when you buy an EMR and they train your medical assistants, they say, get as much history and exam on everybody that you can, and then we'll let that pick our code. And that's why so many people go to having many 214s now. They left off the complexity of the patient's problem. But medical necessity is so important, and it always has been, that the new coding guidelines that we'll talk about are based solely on time or medical decision making. So if you're currently using an electronic medical record and it's selecting your E&M services, just kind of be cognizant of the fact that you really shouldn't be using that thing. You always want to make sure that your level of service is supported by the reason for the encounter and not just based on the history and the examination. We started seeing a lot of cloning in notes when we came out with EMRs. I audited a lot of E&M notes, and I never thought for a minute that I'd see a doctor literally just redate the same note, from a previous visit. But you see that a lot. And cloning means that you're carrying over the exact same note every visit and not changing anything. So that became a problem with electronic medical records. Again, Congress figured that out and tried to reduce the administrative burden associated. We're on page 3 of the 2020 handout. That's right. So you want to make sure about cloning. So that was happening. When I first started in 92 and everybody was on paper, a 99213 only needed one review of systems, and I couldn't get doctors to do one review of systems for a 213. Now a patient comes in for a sore throat and a runny nose, and you get a 15-page note. Have you fallen lately? My wife has skin cancer, and she had to have Mohs surgery yesterday, and this is her second time, and we're in the hospital, and I know you guys have to do this, but it's just I'm sitting there going, oh my God, have you fallen recently? My wife is just like, can we get this over with? Have you been dizzy lately? Do you have a living will? But those HEDIS questions and everything that you have to go over, and it's just like, no, I'm here for this surgery, stupid. Don't you know why I'm here? So it's the same thing. Every time I go to the doctor, it's the same thing. So we're trying to get rid of some of that stuff. And then you've been here and we're trying to get you to do risk adjustment coding, and pick as many diagnosis codes as you can. So you've got MIPS, MACRA, HEDIS, ICD-10, E&M. If you're in the ACO, you have multiple quality measures that you have to do. And then on top of that, we want the doctors to remember that you have to have 10 review of systems for a 204, medical, family, and social. So, if we can just get through this next 12 months, at least your office visits will be a little bit easier. And I thought we could start with what we do the most, and that's established patient visits. Unless you're a specialist, you probably spend a lot of time on 211s to 215s. And those are at the bottom of page 3. They're established patient, outpatient encounters, and I thought we could just review these for a minute. This way, if you don't know a lot about coding, you can see where we're at now and where we'll be going in a few short months. When you think about coding, it's really simple just to kind of think as the severity of the problem increases, ergo the code goes up. So, 212s are traditionally just one stable problem. If you tell a patient nowadays to come back in 2 weeks for a follow-up, nobody's going to come back in 2 weeks. They got a $50 copay. I've got a $5,000 out-of-pocket deductible. If I'm doing better, I'm not going to come back, but that's what a 212 is. 213s are acute, uncomplicated illnesses. You have one unstable or a couple stable problems. If you're an ENT, if you're in primary care, if you're in GYN, these are things that end in the itis category. You have acute illnesses, or maybe you're a patient and you're compliant. You have hypertension and diabetes, two stable problems. Now, if you just look at 99213 on page 3 and go to the very last box in that row, I wrote examples there. One unstable, two stable problems. Do you see that? I'm all about making things simple. And I have been since about 92. Yet doctors still don't know how to code these things. So you would think a 214, which pays about $30 more, would be more problems, yeah? And it is. It's 3 stable problems on meds, or a couple unstable problems, or one stable and one unstable problem. Or if you're a specialist, it's a patient who comes in with a new problem that's going to require major surgery or endoscopic surgery. So maybe you're a patient who had a colonoscopy a couple years ago, and now you come in and you need an EGD, and it's a new problem and we're scheduling an EGD. Or you had a appendectomy a couple years ago, you're an established patient, but now you come in and now you need a cholecystectomy. So these are new problems that are going to require major surgery or major endoscopic surgery. 215s are people who you usually can send to the emergency room from your office. If you're an old coder, your doctor used to send people to the emergency room and then go and do their H&P, and you were always told you can't bill an office visit and an H&P on the same day, but now there are hospitalists. And they're not under your tax ID, they're not under your NPI, so if you send somebody to the hospital, you're still able to bill for your level of service while the hospitalist gets to bill for the admission. They're also good if you bill on time. So if you look at your grid, 99215 was a 40-minute face-to-face visit. And you could document, I spent 40 minutes face-to-face with this patient, and greater than 50% of that time was counseling, and this is what we talked about. So the grid that you have in front of you looks like the one up there on the screen. You got the code. This is fantastic. There you go. You got the code, you got the minutes, you got the documentation. Remember, you only needed 2 out of the 3 key components. But you were able to pick a code since 1992 based on time or based on 2 of these 3 elements. And for the most part, people did really well. You document well. People would pick 213s, and then all of a sudden, people started getting bought by the hospital, started getting put under work RVU contracts, and then all of a sudden we started getting EMRs, and we started going crazy with 214s, and everybody started billing 214s. So I thought it might be interesting for us to look at a 214, just because your doctors are going to be billing those a lot now. So in that first box, if you look at page 3 for a 99214, page 3, 214 says you have to have a detailed history. Now, if you're a coding nerd, you know there's 4 types of histories, 4 types of exams, and 4 types of complexity. The hardest certification test I've ever taken was the E&M. So is there anybody here? I'm sure there is, who took the certified E&M certification. It's the hardest one I've taken. And so I can't expect everybody to know, all the E&M stuff, but it's a pretty tough test. If you ever get a chance to take it, I see one other person took it. Doesn't mean to take it now. It won't do you any good, but because they're changing the guidelines. And as far as I understand, to kind of put everybody's mind at ease, I don't know that the AAPC is going to make some kind of mandatory retest like they did make us do for ICD-10. Okay, so I haven't heard or read anything about that, so take a deep breath. If they could, they would, because that would be another way for them to make $50 real quick. But you want to look at getting a detailed history. So if you're a doctor and you bill a lot of 214s, or your doctor bills a lot of 214s, just pull some notes out one day and really stress to them that we need a chief complaint. That's what CC means. You have 2 options when it comes to the HPI. That stands for History of the Present Illness. Now, if you're new to coding, at the very bottom of that page, I listed the 8 questions you can ask a patient about their problem. And if you're a mom, you know those questions, because every time one of your children had a fever, the nurse would say, have you given them anything for the fever? How high was it? Have they had any other associated signs and symptoms with it? So there were 8 questions you could ask a patient about their problem. Or if you're in a primary care kind of setting, you can substitute the 4-HPI with the status of 3 chronic conditions, and I'll show you what that looks like in just a second. You needed 2 review systems, and if you don't know what review systems are, the federal government identified 14 organ systems that you can ask questions about. And I wrote those at the bottom of the page next to ROS. And then you needed either medical or family or social history. So a lot of times when I audit a 99214, the first thing I think about is I go, okay, you're saying this is a 214. So in my mind, this is a patient with 3 or more chronic illnesses, yes? Or this is a patient who has a couple unstable. Is a 99214 for somebody who has a upper respiratory infection? No, it's not. It's not going to be an upper. Is it a follow-up vaginitis that's resolved? No, it's not. It's somebody who has chronic systemic problems, or it's somebody who's got a new problem that's going to require some major surgery. All right? Then I'll look at the history. Here's some examples of how that would look. So here is the status of 3 chronic conditions. Diabetes is well controlled. The HPI is what I think about my problem. So if you're in a geriatric practice or an internal medicine or a general practice or family practice, the HPI is kind of like, hey Steve, how do you feel about your problems? Now the impression and plan is going to be what the doctor thinks about my problems. The bottom paragraph would be an example of 4-HPI. For the last year, that's duration. Now, when I'm auditing notes, I would just say to myself, I go, is there anything that tells me about the location of this problem, about the duration of this problem, about the severity of this problem, about the quality? Context always messes people up. Context is, what were you doing when you noticed this problem? I got really sick, and still am a little under the weather, but I got sick in Moultrie. So where was I when I noticed I was sick? I was in Moultrie. I woke up, so that was for a week. So I had to go to the doctor on Thursday when I was in Moultrie. A doctor that I audit. It's just, you can't make it up. But I'm like, I've audited you before. Why am I going to the doctor who fails his audits, You're going to ask me any questions about this? And then I'm sitting there going, you told me to take Mucinex. Can I take that with my Depakote? Are you looking at any of these 9 pages of paperwork that I filled out? Oh, okay. The biggest thing I can talk to you about is when you're doing the review of systems, you don't want to just ever refer to the HPI. A lot of times doctors are trained by attendings. And attendings are employees of the hospital who are getting paid, not on production, but just on training. So a lot of times doctors are trained by people who don't understand coding rules. One of the things, if you're taking notes, and this is true, even if I think you go to page 7 of that handout, there should be some hospital codes. Page 7. Oh, heck, I have a handout. I could look. Yeah, page 7. Ooh, this is good paper. You guys copied this stuff on Jessica. If you look at 99223, which is kind of the number 1 H&P code that we use in Georgia, do you see that code 99223? If you're a specialist, that's probably the code on page 7 you're going to use for a consult. That code requires how many review systems? 10. You see that? It says 10 ROS in the first. Review systems for you new coders, or coders who don't know E&M coding, which is cool, is questions you ask, like, do you wear glasses? Are you having an upset stomach? Physical exam is where you actually touch a patient, okay? The one thing you don't want to do for the review systems is say, review systems as per HPI. You don't ever want to review. In Georgia, our Medicare carrier doesn't allow you to refer to the review systems. What you have to do is you have to list a couple review systems, like Steve, if I'm admitted to the hospital for shortness of breath, my review systems would have to have a couple questions out of those 10 related to why I was admitted, positive or negative. And then you'll notice, even at the bottom of page 7, the words all other systems reviewed were negative. Do you see that? All other systems reviewed were negative. It's the last sentence next to the ROS line. All other systems. So always make sure that if your doctors bill a lot of higher E&M codes, that one of the big problems you'll see is in the history, they'll say review of systems as per HPI. Or it'll say negative, otherwise as noted in HPI. You can't do that in Georgia. The other thing you can't do in Georgia is for family history, you can't say non-contributory. You can't say non-contributory. These are words to avoid in the state of Georgia. You always just want to say negative for, so if I get admitted for chest pain, family history negative for heart attack. Something negative or positive, right? Never non-contributory. So we've went through all these rules that are just redundant and stupid and cost doctors tens of thousands of dollars. And we're trying to get rid of all these rules. But this is all we have to deal with for the next 11 months, all right? As far as the physical exam, we had other limitations. So if you go back to page 3 and look at the office notes, I hope this works for you. I kind of want to show you where we are and why why they are getting rid of these things. So if you go back to page 3, a new patient code that we all love to use now is 99204. Do you see it? Right, so go to 99204 up at the top, new patient code. That's the code everybody wants to use. How many review of systems does it need? 10. You see that? Can we say negative as per HPI? No. Can we say non-contributory for family history? No. Now you go to the next box and it says physical exam. You see that number 8? Would you circle the number 8? 99204, just circle the number 8. In Medicare's world, in the AMA's world, there's a difference between organ systems and body areas. And for a 99204, there's an expectation that you're going to examine organ systems. Now at the bottom of the page is the word exam, and I list organ systems down there, right? Is back in that list? Is neck in the list? Is head in the list? So this is another stupid rule that the government came out with that made no sense. Doctors are trained, if I go to the cardiologist, they're going to examine my thyroid, my extremities, my neck, all these things that technically don't count under an all-inclusive system. So then, some of you are familiar with what's called the bullet system, and that came out around 90, we call them the 97 guidelines. And that's where the AMA came out with these subspecialty system exams, which were also ridiculous. So we keep trying to pour gasoline on this fire to get it out. But what I would tell you to do is that normally when doctors get audited for high-level codes, the first thing they mess up on is their review of systems. The second thing is non-contributory. And the third thing is when I look at higher-level codes, they don't do an 8-organ system exam. They usually do 6 or 7, and then they have a couple in there that don't count. If you go to page 7, the number 1 admission code requires how many organ systems? Page 7. Now see, once they leave the confines of your office and they go to the hospital's EMR, then we have to count on the hospital. And they're not picking their codes based on history exam and decision making. They're picking their codes based on what they thought was wrong with the patient, like on a DRG or an IPP. So they're doing it a little bit different. And some hospital EMRs aren't compliant either. All right? So you have to audit your notes, and I have contracts with hospitals all up and down the East Coast where I just audit. And I go in and I work with the EMR team, and we just change words like abdomen to gastrointestinal. We change lungs to respiratory. Are the codes on page 7, are the documentation for those codes changing in 2021? Nope. They're not changing. On page 3, are they changing? Yeah, changes is coming to page 3. Changes are coming. But see up here on the screen, some of those words like constitutional, eyes. Eyes and ears, nose, throat are separate. Instead of neck, if you palpitate the lymph nodes, they'll give you credit for that, but not for the neck. Cardio instead of heart, respiratory instead of lungs. Systems. You have to go back to high school biology, which I flunked. I got in with the wrong crowd. Tom Pointer and Jeff Lundy. Yeah. Now we're all friends on Facebook, and yeah, it's great to reminisce on your high school failing days. Some good ones that your doctors overlook sometimes: skin, warm and dry to touch; psych, alert and oriented ×3. But you see, I've spent a lifetime working with doctors, working on these little nuances. And then you might say to yourself, or doctors would say to me, well, why wasn't my EMR set up right the first time? And I'm like, well, because EMRs aren't set up for compliance, they're set up for integration between you and the hospital. So your EMR is not compliant. And I've lost one of my largest clients because of that, because I tried to explain to them that this EMR is going to get you in trouble if you implement it without just changing. If you give me a day, I'll go in there and we can change it and it'll be fine. And the most confusing component of coding has still always remained the medical decision making. Now, what I've tried to do is make it simple for you. So on page 3, if you put your finger on 99203 and you slide all the way to the right, do you see that? Over-the-counter drugs, antibiotics, do you see that? Page 3. All right, so I go to the doctor, new doctor, on Thursday. He says, Steve, you've got a viral infection, upper respiratory virus. And I go, all right, so you give me some, what do I, you're going to give me some medicine or something? What do you do? And he's like, no, go get some Mucinex. Okay, so what level of service am I going to be? A 2.0 what? Come on, think. 203, right? Simple. He told me to go take some over-the-counter drugs, right? You ready to code? Everybody say yes, come on. Yes. How many HPI do I need for a 203? 4. How many review of systems for a 203? 2. Look at the exam. Do you see where it says, what does it say for the exam?
2 to 7.
Yeah, 2 to 7, and then in parentheses it probably says extended or 2 by 2. In Georgia, a detailed exam is where you tell me 2 things about 2 parts of the body. That's all. 2 things about 2 parts of the body. That's Georgia Medicare. And that's about what the guy did. You get it? Simple. Now, on your own on page 3, let's say I was a new patient that came to you. I teach people to code backwards. So always start with the complexity. So let's say I move to Athens, right? And I come and see your primary care practice, and I have hypertension and diabetes. And your doctor refills my metformin and my lisinopril or losartan prescription. So, am I an 05? Are you going to send me to the hospital? No. 04 says prescription drug management, things like that. That's what an 04 is, right? You got it? Everybody? Simple. That's how coding works. If I'm a specialist here, if I'm a surgeon and I see a new patient who needs a laparoscopic cholecystectomy, is that an 03? No, it's an 04, right? Unless, could I ever be an 05 for me? Yeah. Now, to figure that out, you just turn the page. So go to page 4. See that that box up at the top? We had 3 boxes that we use to calculate complexity. So this top box is the risk box. You see where it says risk points? All right. And then the second box in the bottom left-hand corner is we used to have to we still have to calculate data points, and then we have these diagnosis points. Well, in this high row here, for new patients, if you scheduled elective major surgery, open, percutaneous, or endoscopic, on a patient who had documented risk factors, that put them at high risk because you could bill a level 5. Okay, so if I ever needed major surgery because of my comorbid conditions, I'd be a level 5. Now there's 3 boxes up there now, and under the new guidelines, they've taken those 3 boxes and just turned them into 1 box, and I'll be explaining that to you in a little bit. But for my friend over here who took the certified E&M coding, we have to look at, I think we're 50 E&M notes, and we had to answer 3 questions on each of them. We had to code 3 things on each of them. So you'd calculate data points, whether or not something was new with additional workup, if it was an established worsening problem, if we did an independent review of an imaging, tracing, or specimen. Now, we'll still have to do that for our hospital levels of service, but for the office, that's all going to go away. The way the system works is at the top of the page. Do you see this little thing? It says level 4 visits. You got to have 3 points from any 2 of the 3 boxes below. Do you see that? And then for level 5 visits, you need 4 points. Well, if you look over here at moderate, you see how that's worth 3 points, highs are worth 4. And you calculate the findings from these 3 boxes, and you do the best 2 out of 3, and that's how you come up with the level of service. And it's been good for me, because again, there's not many people in this room who've ever understood it totally. You should always make sure of now if a problem's new to you or established. That's what coders have always told you. You don't need to know why necessarily, but it helps you from a coding standpoint. So if you're seeing an established patient who has a new diagnosis, that might be worth 3 points instead of an established worsening problem that's only worth 2 points, you see? So all those little points get to add up. So, you know, Weight Watchers commercials are out real big right now, and if you've ever done that, like I have and failed miserably, they had the point system, and I just saw this thing on Facebook yesterday about I'm sure you all have seen it, but I don't get on Facebook that much anymore, and some Girl Scout people set up outside of a Weight Watchers. I thought that was so cute, so savage. And then in Colorado, you know, they're outside of the marijuana places, you know. It's really smart, man. Kids are smart nowadays. But it's important to know whether something, now you ready to take a first little note? One of the things to start educating your physicians is this. Under the new guidelines, because we don't use point systems, we're going to go with this at goal statement. Patients are either stable, which is meaning they're at goal, or they're not at goal. So for example, my blood pressure a few months ago was up to like 160/90. I guess it was about 3 or 4 months ago, and I went and saw my nephrologist, and he goes, dude, your blood pressure's up. And I go, yeah, okay. And he goes, well, you're carrying a lot of fluid. So he started me on a new diuretic, and I went back and saw him a week later, and it was like 155/80. Still not at goal. It was better, right? So, coders, am I established stable or established worsening? Well, under the new matrix, I'm getting better, but am I at goal? No. So I'm worsening. So these are the kind of things that we're going to talk about now, because the point system for established better, established worsening, new with workup, new without workup is going to be going away. So I'm trying to get my clients to start thinking about the top 10 or 15 diseases that they, treat, and start figuring out what goal is. BPH. What's your goal going to be for BPH? You might have to start listing that. Patient presents today, the BPH is better than last visit, but it's not at goal, which is this. Because there's going to be a huge shift in the way we code new patients and established patients moving forward. So you want to start thinking about that now, and I'll talk a little bit more about it in a few minutes. But are things at goal? Data points. The system that they've put together for data point calculation is really confusing. It's not the same system. They specify that if you're doing tests in your office that you're billing for, forget about it. You're not going to get any credit. So if you're ordering a CBC and you're doing that in your office, an A1C and you're doing it in your office, an EKG, even if you're doing it in your office, you're not going to be able to count that. So about the only thing that you get a lot of credit for nowadays is independently reviewing stuff that comes from outside of your office. So in the past, I'd look at things like, did we order an EMG? Did we order an EEG? Did we order an X-ray, an MRI? And I could give you at least a point for that. I might not be able to give you 2 points if you independently reviewed something that you were getting paid for. But as I go over the new guidelines, just remember that the data points are going to be really hard to achieve unless you're in a specialty and you're getting a lot of old information into your office. But right now, you've heard over the last 20 some odd years, always document if you're ordering tests, if you're ordering old lab records, if you're ordering old medical records, If you're documenting relevant findings from the review of old records, these things are still important for hospital and nursing home, but they're not going to matter much in the office anymore. Here's an example of me. I went to the doctor last couple years ago, I guess, and I was having a little bit of chest pain. And she coded me as a 215 based on my data points, which again is going to be much more difficult moving forward. And then I went across the street and watched the second John Wick movie. So you don't have to admit people in the old system to get 215s. Now watch. For a 215, I needed 4 points from 2 of the 3 boxes. So these were my diagnosis points. My A1C was good. I was having the chest pain, so they gave me an established worsening problem there for the hypertension. Sleep apnea was fine. Chronic kidney disease was good, but she hadn't followed up with my doctor. She did a microalbumin on me that day. So I had enough diagnosis points. She ordered the A1C, an EKG for the chest pain. Then she sent me out for a echo. And she requested my old records from Dr. Brazina. So I had 4 points. So even though I was moderate complexity, we had more than 4 points from 2 categories, so that would have made me a 99215. Then we look at some other examples. You know, here's a new strep throat. Remember we talked about strep throats are usually level 3s, yeah? On page 3, because we're going to prescribe, you know, over-the-counter drugs, new problems. New problems with workup means after you leave the office. So when I went to the doctor, I got a nose swab for the flu vaccine. So I was a new problem, no additional workup because I was all done before I left, and he got to bill for the nose swab. So in the new system, he can't even get credit for the nose swab because he got paid for the nose swab. Follow-up hypertension and diabetes, remember 2 stable problems? I told you was a 1-3, right? On your grid. So instead of doing all this math in your head, if you look on page 3, last box, I tried to just convert all that into what you've heard me call over the past years, simple trailer park language. You know, just let's make it simple. Don't make it hard, okay? The last option that we have for right now is documenting things on time, and this is another big component that's going to be changing in the future. So if you go to page 3, all those codes have time on them. You're required to document 3 things if you want to pick a code on time. Your total face-to-face interaction with the patient, that more than half of that time was counseling, and what you talked to them about. That's it. Let me see if I put it on this handout. I think I haven't. No, I haven't. So yeah, you just document 3 things. So if I had a note, and I was an auditor from Blue Cross, and you wrote, an established patient, I spent 30 minutes face-to-face, greater than 50% of that time was counseling regarding the current treatment plan, diet and exercise, compliance with medication, what level of service could you bill? 214, right? Because a 214 would be 30, scratch that, 25 to 39 minutes face-to-face with a patient. And it has to be the doctor's time, or the PA's time, or the nurse practitioner's time. It can't be your staff time included in that. So when we looked at established patient visits, the higher the code, the more complex the problem, simple, easy. Once you learn that system, everything else is pretty easy, because then we jump into new patients, and they're the same thing, same box up at the top. Under the new matrix, we're going to get rid of, we're going to see in just a minute, 99201 will go away, because it has the same complexity as 202. Most people never pick a 202, because that means you're not treating a patient. 203s over the counter, 204s a systemic disease that you're treating with medication. And 205s are usually high-risk patients. Higher the code, the higher the volume. You've learned the 8 organ system exam, the 10 review of systems. You can't say non-contributory. So again, when we look at the history, everything's listed at the bottom. all the stuff that we had to go through. Just remember this if you're kind of knew a little bit about E&M coding, but maybe you didn't know a lot. Hey, there's my pulmonary. Are you still in pulmonary in Athens? Pulmonary? I've gotten cotton mouth. I'm still using the same CPAP machine that you guys started me on years ago. I've never missed a night. I don't miss a night. I get 2 of them now. Physical exam we talked about. 203, do you see that on your grid? That's a real common code for primary care, 203. You got to tell me 2 things about 2 parts of the body. That's it. 2 things about 2 parts of the body. And then decision making is that big confusing matrix on page 4. All right? So I'm trying to explain to you in 30 minutes what I've been doing since 1992, and you're still going to either get it or you don't get it, and that's fine because it's all going to go away. It's all going to go away. But I wanted to introduce it to you so that you could, you could appreciate the kind of stuff that your doctors have to go through, that your mid-levels have to go through, and they're fighting it. They don't want to do it. They fight it at every step of the way. Now, one last thing to talk about that's going to have a little bit of an impact is I always get asked this question about what do I do when what do I do when I have a patient who's not in the office and I'm doing work for? And the answer is there's some codes called prolonged service. They're not in your handout. Not yet. I just wanted to show them to you because I don't want you to freak out and go back and start using them irresponsibly. But I have to go over them with you a little bit because I'm tired of people coming up at the end of this talk asking me this question. Like, mom's in the nursing home and the family wants to meet me afterwards. Come to the office and talk to me about her, right? Does that ever happen to you people? Or you see a patient like me, you order a battery of tests, and then all the tests come back the same day or the next day, and while you're at your kid's soccer game, the doctor's at the office late going over all my crap, and I'm not there with them. Tell me that happens all the time, right? Well, a couple years ago, these 2 codes came out. This one I want you to write down, 99358. It's prolonged service before or after direct patient contact. And the reason I have to introduce it to you is it's going to cause some confusion coming up in your future with the new coding guidelines. Before and or after direct patient contact. I have doctors that I work with who do a pancreatic cancer surgery in Baltimore, and before they'll consider you as a candidate, you have to send all your medical records to them. Well, before this code came out, we couldn't bill for that. But now we can. So we can bill insurance companies for stuff that we do before the patient even comes in. All right? Now, this code is in your CPT book. It pays about $138, $113. Just like a man to over-exaggerate, right? Unless it's something I want. Oh, it's only $50. $113. Medicaid doesn't cover it. Medicare does. Most commercial plans do. This grid's in your CPT book, and it's on Medicare's Carrier Manual 104. So you just document start and stop time. Started at 8 o'clock, finished at 8:15, reviewing Steve's MRI of the head, showed this. 9 to 9:30 did this, it showed this. You'd have to have a note, it has to have start and stop time, but it is possible to bill for prolonged services before and or after direct patient contact. For right now. You could do this on the same day right now. It's not an add-on code. So because it's not an add-on code, you could see me today and bill this code tomorrow, even though I'm not in the office. It's not an add-on code. So it doesn't need a modifier. But in the future, the time codes are changing. So now go to your 2021 handout. And go to page 1. And at the bottom of that page, write 99358. Page 1, write 99358. Now, 99358, remember, is prolonged service before and or after. And right now, you can bill that on the same day. But in 2021, you won't bill that on the same day. You never can bill, so write that on page 1. 99358 cannot be billed on the same day as an E&M. And I'll tell you why. Because in 2021, when you pick a code, you'll now be able to use same day time. Same day time. So look at 99204. You see that 45 minutes? See that? That time includes everything you do on the same day. So watch, look at this slide up here. So if you're a doctor, I'll give you my example. When I go see Dr. Sharma, they put me in an exam room. She goes over my visit for the last visit out in the hallway. That time would count. She comes in and she sees me, examines me, whatever, counsels me, goes out in the hallway, does what? Orders all my medicine, types up my note. Yeah? I get my lab drawn, it comes back that night. What does she do? She goes over it, she reviews it. Now, she can count that whole time, all that time that day. It's no face-to-face, it's not more than 50% counseling, it's the entire day. One of the things that you can expect to happen if you ever do, does anybody here bill chronic care management? Okay, when you open up a chronic care management program, as soon as you open that up, a clock starts ticking. So maybe one of the things that your EMR will start doing is every time your doctor accesses a medical record, a clock will start. But as coders, you might want to just kind of start introducing this to your doctors. You might have some doctors in certain specialties that spend a lot of time outside of the patient room on that day doing stuff, because you're going to be able to pick your code based on time or on complexity moving in 2021. So because you get to add up the total time for that day, there'll be no need to do prolonged service time on the same day, because you'll just add it to your regular time. All right, so going back in time a couple slides, let's talk about where we are on page 1. Initially, some of you heard that Medicare was going to go to a blended payment model where they were going to pay one rate for levels 2, 3, and 4, and one rate for a level 5. Well, CMS threatened that to the American Medical Association because the American Medical Association would not change the coding guidelines. So the AMA changed the coding guidelines, CMS adopted those guidelines, and they've published them all over the internet. They'll be published in the 2021 CPT coding book, and I'm going to share some of those with you today. They'll go into effect for all insurance companies January the 1st, 2021. Then basically what happened is you're going to have 4 new patient codes and 5 established patient codes. You'll have the same time, same day time ranges. Now, whether or not Medicare adopts these times or changes their times, I don't know, because it's only February, hello. The biggest thing to notice, though, is the RVU is going up considerably for physicians. So I'm going to share that some with you today. There's going to be new add-on codes that are 15-minute increment codes. So right now, like if you did a 99205 and you wanted to bill it on time, you'd do 60 minutes. But if you went 75 minutes, you'd do 99205 with this new add-on code. Now, the 99XXX just indicates they haven't come up with the actual code yet, because it's only February. So each additional 15 will have a 0.61 RVU, which is basically, an RVU is about $40 rounded up. So each additional prolonged service code will be worth about half of that. So $24, $24. Why are they doing this? So that you can start spending more time doing HEDIS, MIPS, MACRA, risk adjustment. because all that stuff, your annual well visits. If you're in primary care, this is huge for you, and it's a good time for you to start thinking about, what am I going to do now? Because now I could spend a little bit more time with my patients. My work RVUs are going to go up. I'm going to show you in just a little bit the impact financially this is going to have for your Medicare population. So hopefully we'll get an opportunity to start recouping some of the time that we're spending on these patients. So this was that list of things that's in the guidelines that tell you all the stuff, all the elements that count towards time. It's not in your handout. More good news. Medicare acknowledges that some professionals have patients who have multiple complex conditions or a single complex condition that requires a lot of extra work even after that first day. So not only will you be able to bill an E&M code like a 214 a little bit easier, but there's going to be a primary care add-on code. It'll be a Medicare HCPCS code, probably a G code. And I just wanted to introduce it to you because it's going to pay you extra money as well. Now, it is an add-on code. Visit complexity inherent to evaluation and management associated with medical care that is serving as a continual focal point for all needed healthcare services, medical care that is part of an ongoing care relation to a single, serious, or complex chronic condition. What does that mean in simple language? Well, CMS stated that although the use of this code is not restricted by a specific specialty, they do assume that certain specialties will report this code 100%. So if you're in one of these specialties, you might want to write this down. Family practice, general practice, internal meds, peds, geriatrics, NPs, PAs, endo, rheum, heme, uro, neuro. So all these specialties who are treating people will have this additional code that's going to be adding about an additional $18 per visit on top of the E&M raise that you're going to get next year. It'll be an add-on code, so it won't require a modifier. And it's not based on time, it's just the complexity of the patient, which Medicare will probably publish. Now, some of you are very smart, and you're thinking, wait a minute, how can they start paying us more money for this stuff when there's only so much money in the bucket, right? So I don't like bringing up, well, I do like bringing up politics, but if you're, I don't want to get in trouble. But there's only so much money in the bucket. You can't keep taking money from one place. So there's some of you who are going to get hit really, really hard in your surgeries because they're going to be taking money away from you to pay for these new E&M codes. You ready? Everybody got you? If you're over 40, get your glasses on. Here's some of the specialties. Now, if you're in anesthesiology, you're going to get hit. Look at this. Audiologist. Cardiology, 9% cut. Look at some of these cuts. Psychiatrist, colon and rectal surgery. Emergency medicine. But look at family practice. If you're in family practice, endocrinology, you're getting huge raises. Huge. About time, right? This list is really small, but this is all the different specialties, and I'll put this up here at the end if you want to come up and look at it a little bit better. I mean, there's no way I can, it only fits on one screen. But if you're wondering, at the end, I'll put this slide up here, and then you can come up and take a picture and go back to the office and maybe get your doctor to do that office-wide cruise this year instead of next year that you've been waiting on. Now, if you look at page 1, a lot of the things that I've explained to you, I've put on page 1 of that handout. So you have the codes there. Do you see that? Then at the very bottom, the 99XXX, each additional 15 minutes, yes? And then I put the grid down there about how to use them. And then I even put that GPCIX code in there. Now look at 99204, which remember I told you was the code that we all like to use. It says medically appropriate history, medically appropriate exam. What's missing from those boxes? 10 review of systems, medical, family, social. Do you still have to do a history? Yeah. We still pay malpractice insurance, people. But as an auditor, the most important thing that we're going to look at is the chief complaint. Why are they coming in? the chief complaint is always going to have to match up with what you diagnose them with. We're going to need to find something in the history or the exam that supports the 15 diagnoses that you want to bill your level of service for. But remember, I told you time or complexity. Now, you don't have to look at this, but this is if you go to Google today and just Google 2021 EM coding changes, this is probably what's going to pop up. Now, remember that table of risk that was in the last handout on page 4 that had 3 boxes, risk, diagnosis, and data? This is what it was replaced with. Now, before you panic and go, he didn't give us any handout, I've already spent my life and my evenings upstairs in my office with my chihuahua, and I've went through all this and I've created handouts for you that will explain all this to you. So I've done the work for you, so just relax. Nobody does this for me. See over here, this is from the AMA. This will be in your CPT book. It says 203 and 213 is low complexity, and that's if you have 2 or more self-limited or minor problems, 1 stable chronic illness, or 1 acute uncomplicated illness or injury, right? You see that up there? Now there are 3 columns. You got to meet the requirements of 2 of those 3 columns. Now, many of you today may not know the definition of a minor or 1 stable chronic illness or an acute uncomplicated illness or injury. So if you look at page 1, I've mimicked everything on that grid here. This is the bird's eye view of everything. Do you see this on page 1? So a 204 is how many minutes? Minimal minutes. 45. And it says 1 chronic condition that is what? Worsening. Okay. Now turn the page. And that's the overview for 211, 212, 213, 214, right? They did theirs on 1 page. I did mine on 2 because I wanted to include the time. But look at 214. It says 1 chronic condition that is worsening, or what? Now listen, right now 2 stable chronics is what? A 3. So here's what I want you to do that's going to be a little tricky. God, don't get upset. Take the first handout and turn to page 3. This is like that Facebook thing that was going about where you had to post your LinkedIn picture, your Grindr not Grindr. Sorry. Tinder, that's the one. Sorry. Where's my head at today? Now, if you look at 99213 on the up and down handout from 2020, it said 1 unstable or 2 stable, right? That's a 213. Now look at the 2021 guidelines. 1 unstable is a 1-4, 2 stable is a 1-4. Are we going to see more 1-4s? Yeah. Oh. But you have to know the difference. What's a stable chronic condition? Well, again, don't worry. There's more in the handout. This is the overview. The AMA CPT book defines that. Now don't freak out because there's more to this handout. So I'm going to show you because you're women. And unlike that guy on The Bachelor, did anybody watching The Bachelor this year? That is the most I don't know women guy I've ever met in my life. My wife had surgery yesterday. I'm sick, but we're still watching The Bachelor from 8 to 11, just going, this guy is a complete numbskull. But man, my life is so much better for it. Stable chronic condition. What's a stable chronic illness? This is important if you're a coder. It's a problem that has an expected duration of at least a year or until the death of the patient. Now, a patient that is not at their treatment goal is not stable. Didn't Steve talk to you about getting your doctors to incorporate that? Because we're doing away with the point system, which my friend who took the EMC, that's a hard test, man. I think they pass you on it just because they don't want to fight with you on why you didn't pass it. Some examples of stable chronic conditions may be hypertension, non-insulin diabetes, cataract, benign hyper. These are things that are stable. So 1 stable chronic illness in 2021 is going to be coded as what? A 3. Right now it's a 2, but it'll be a 3. Imagine your coding grid going from the left over to the right. It'll shift. Now here's the one catch. One catch. If you're in primary care, this is a big catch. Go to page 1. Right now, if I came to see you in Athens as a new patient with hypertension that was controlled, this is how good you guys are going to be if you've listened to me today. I'm a new patient, and my blood pressure is 120/80, and you rewrite my prescription for losartan. Don't say it out loud and embarrass yourself unless you're sure. Look at my grid. What am I? Am I an O2, an O3, or an O4? I have one stable chronic illness. An O3, right? So if you're in primary care, your new patient levels are going to go down unless you have how many chronic stable conditions? Or what if I came to see you as a new patient and my blood pressure was 160/80 and it wasn't at goal? Then I'd be a 4 because now I'm not at goal. You see what you're going to have to start doing? Now, if you coded me as an L4, how many review systems will I need in 2021? It don't matter. Right? So as you slowly start introducing this to your doctor, there's no person in this room who couldn't code. If I came to see you and I needed major surgery and I had no risk for that surgery, so I'm getting major surgery without risk factors. 4. I'm having a GI bleed, I'm otherwise healthy, and you schedule me for a screening colonoscopy. An O4. Well, that wouldn't be screening, but it'd be an O4, right? So just about anything on there you could use. My wife had Mohs surgery yesterday. It's a 90-day global. She just got back yesterday from the hot chocolate run in Atlanta. She's healthier than I am. I'm twice the man she married. She reminds me all the time. Literally. I used to be able to wear her skirts. Oh, come on. You're telling me that none of your husbands have ever put you, no? No. Okay, well, that explains a little bit. But she had major surgery, so she'd be a new patient level. Major surgery, 4. Yeah, there you go. An acute uncomplicated illness or injury. This is on the list. These are things like cystitis, rhinitis, sprains. These are the words that you're going to see in the handout in just a little bit, but this is what the AMA has in their CPT book, these words. Now, so that you don't have to remember them, I've put them in another place in the handout, so just, like I said, relax. Chronic illness with exacerbation. This is an illness that is acutely worsening, poorly controlled, or progressing. You see, that would be my blood pressure when it was up. But if you don't tell me that it's not at goal, they're not going to assume this. So another word you might start using is exacerbation. So my blood pressure's, you just can't say hypertension. You'd say hypertension, exacerbation, increase. Diabetes, A1C elevated, exacerbation. Increased metformin from 500 to 1,000 milligrams twice a day. You see? See key words? This one's been around forever. If you're referring patients out of your office for pelvic pain to a GYN or to a general surgeon for an undiagnosed new problem, that's going to be level 4s. Chronic illnesses with severe exacerbation. That word's been around forever. Acute or chronic illness that poses a threat to life or bodily function. These are common. Sepsis, renal failure, AKIs, and abrupt change in neuro. These are level 5s. All right? Now what I did was take all that, the bird's eye view, the fancy words, and because I don't know why, probably because I don't ever want to work again, go to page 3, and I've put it all together on page 3, 4, and 5. So look at the grid here. 203, do you see that? Put your finger on 203. And I put down 2 or more self-limited or minor problems and that definition. Do you see? One stable chronic condition. This is just another technique that you can use with your doctors. Now, I didn't do this for you. I did this for me because this is like 15 pages and I'm not smart, you know. So I had to figure out a way that it would make sense to me. So I hope that it makes sense to you, but I figured if I took all the different pieces of information and put it on a page, I wouldn't have to memorize it. So if you look at 203, it says at the bottom, one acute uncomplicated illness or injury. So we're still going to code itises as O3s, right? But the big change is that one stable chronic, all right? That one stable chronic. So if you're in primary care, do your patients only just have hypertension now? No. Your doctor's going to have to document all their chronic conditions. You turn the page to the O4, and I outlined there what the O4 and the 1-4 are. So if you're in primary care, the good news is that your 1-4s should go up to probably 90%, I would think. One or more chronic illnesses that is acutely worsening, or two or more stable chronic illnesses. Your O4s and 1-4s are also going to be for people who need major surgeries. There's some problems with this that we don't really understand that much about. I mean, where is I guess you could say that any kind of systemic problem that you're having that requires major elective surgery could be an acute illness with systemic symptoms or an acute complicated injury. They haven't really come up with a way to really focus in on this for me that I can go into a general surgery practice and say a laparoscopic or a cholecystitis fits into this category. But it would have to be one of those because the risk column over there talks about decision with major surgery. So to me, the only downfall that I see in this whole grid is new patient primary care level 4s if you're seeing a new patient with one systemic problem only. Those are going to be O3s. Then you go to your O5s on the last page. And this is just putting the table of risk together. And there's some examples of one or more chronic illnesses with severe exacerbation, acute myocardial infarction. You're probably going to use that high column in the first column after the word high, where it says one or more chronic illnesses, and then that last column where it gives you the high risk. The middle column is the data column, and that's the one that's really hard to sufficiently document because anything that you order out of your office that you're going to get paid for is not going to count anymore. So I think this is where we are, yeah. So MIs, So they're putting this out here as another reminder too that in the future, hospital coding will go to this. But for right now, you're going to need these pages, plus if you do hospital or nursing home, your other handout, because that's going to be another table of risk. So you'll have two tables of risk moving forward. Again, unless Medicare somehow publishes that they're going to dump their current AMA table of risk and just use this for everyone, which I don't think they can. So again, just to kind of summarize here, if you go back to page 1 and 2, this is probably what you're going to use the most in your office, page 1 and 2. And then you'll have those other pages to kind of quantify what these definitions are. So you could probably just copy these front and back and start getting in a little bit of time. Talk to your doctors about the amount of time that they're documenting with their patient. And just know that it's February, right? So we don't know. Is Medicare going to make me do start and stop times to calculate total day time? I don't know. I doubt it. They don't make me do that now to bill on time. But I mean, how many 205s could you bill on time in a day if you're only there for 8 hours, right? So it's the same old scenario. But the big thing is the administrative burden for this goes away. That'll help you out. Think about your medical assistants not having to document and pull over all that old stuff every visit. So at least we can look forward to that. So we talked about the 2020. Now, for many of you, is this the first time you've heard a 2021 talk? You know, it's not the end of the world, right? And I told you ICD-10 wasn't going to be the end of the world, right? Risk adjustment wasn't going to be the end of the world. I remember being over at St. Mary's giving a talk telling there were no HIPAA police, and I got bawled out by somebody. I can't believe you called and told him that nobody in this room went to jail for HIPAA. So Steve, I've never steered you wrong. And that was way back in the 90s, right? I didn't tell you anything wrong was going to happen. And this is the first time, if you're in primary care, that you're going to get a big bump in pay. But before we move, I always like to show my favorite guy. Does anybody have a question that you'll understand if I say we don't have an answer to right now? Did that help a little bit? Yes, ma'am.
So I got a question on, like you said, if we order the test and we're going to get paid for it.
Yeah.
Say you order an MRI.
Uh-huh.
You're not sure if it's going to be done at your facility.
Yeah.
It's going to be sent out.
Uh-huh.
Do you count that in your data?
Yes. You'd get a point for that. But we're going to talk, because she has taken the test. But the trick is that once you order it, you don't get any more points when the results come in and you read it again, just like now. Yeah. So one of the things I told you guys I would do as we're getting ready to close is I would put this up, because here's the biggest thing to take away from this. You should walk up here if you're not in primary care and see how much you're going to be financially impacted by these changes in 2021 on your way out. Okay? I mean, that's really an important thing to think about. Because some of you in specialty societies are going to get hit really tough. All right. Thank you guys for coming out. Thank you.
Thank you, Steve. Yeah, Steve, is it okay if can they take a picture of that, or?
Oh, yeah, I'm going to leave it up.
Okay, so y'all can get your phones out and take a picture. That's what I would do, because it's hard to remember things from something's going to happen as soon as you walk in the door at work. So you're welcome to snap a shot of that. Thank you, Steve. Thank you guys for coming out. I hope you have a great Tuesday, a great rest of the week.